Good morning, ladies and gentlemen. It's now 10:30, so it's time to start this state-of-the-art session of this morning. My name is Peter Reitsma, and I have the honor and privilege to chair this session. First, a general announcement, and that is that photography, filming, and video recording of this session is not allowed, so please refrain from putting up your iPhone and making pictures. There are two talks in this state-of-the-art session. One is more fundamental, basic in nature, and the second one is more clinical in nature. They are both given by ladies from Italian descent. And the first speaker is Elisabetta Castoldi, who moved from Italy to Maastricht to do her work, and she will talk about the modulation of alternative splicing of coagulation genes, a new approach to prevent venous thrombosis. Elisabetta.
Thank you, Professor Reitsma. Ladies and gentlemen, it is my great honor and privilege to be here, and I would really like to thank the ECTH board for inviting me and for offering me the opportunity to discuss with you this idea of alternative splicing as a potential target for therapy of venous thrombosis. I have no disclosures, although I would like to stress from the beginning that I'm not a clinician and therefore not really optimally placed to talk about prevention of thrombosis, certainly not after the impressive presentation of Professor Bühler yesterday. Anyway, so in the last 50 years or so, we have learned quite a lot about the etiology of venous thrombosis. And we now know that it is a multifactorial disease and that coagulation is really central in the pathogenesis of the disease. So whenever procoagulant factors prevail over anticoagulant factors, the risk of VTE is elevated. Traditionally, we have very much focused on quantitative variation of coagulation factors and coagulation inhibitors as determinants of VTE risk. But today, I would like to argue the case that qualitative variation may also be important, as in the case of factor V Leiden, which changes the properties rather than the levels of the protein. A major mechanism by which qualitative variation in the human proteome is generated is the process of alternative splicing. As we all know, human protein coding genes are formed by small coding segments known as exons and much longer non-coding segments known as introns. During the process of splicing, introns are removed from the primary transcript and exons are joined together to form the mature messenger RNA. However, since some sequences in the primary transcript can function sometimes as exons and sometimes as introns, the same gene can produce multiple transcripts, which in turn encode structurally and sometimes also functionally different protein isoforms. And this is not just a curiosity, but a very fundamental phenomenon that concerns more than 90% of the human protein coding genes, including coagulation genes. Moreover, since alternative splicing is influenced by genetic variation and acquired factors, there is quite some inter-individual variation in the expression of splicing variants. And this may have clinical implications, as suggested by this recent paper that demonstrated that a surprisingly high fraction of all SNPs that have been associated with complex traits do not change the levels of proteins, but rather their splicing patterns. So in the next 20 minutes or so, I would like to address two questions. First of all, does alternative splicing play a role in VTE pathogenesis? And second, if this is the case, can we target alternative splicing to prevent VTE in thrombophilic individuals? For the first question, I would like to present two examples of splicing variants with clear phenotypic effects, namely the fibrinogen gamma prime chain and factor V short. Several years ago, the Leiden group reported the identification of a new genetic risk factor for venous thrombosis in the fibrinogen gamma gene. And in an attempt to elucidate the underlying molecular mechanism, they observed that there was an inverse correlation between the levels of fibrinogen gamma prime, a particular population of fibrinogen molecules, and the risk of thrombosis. In particular, individuals in the lowest quartile of fibrinogen gamma prime levels were approximately 3 times as likely to develop thrombosis than individuals in the highest quartile. And this was completely independent of the well-known effect of total fibrinogen on the risk of VTE. But what is fibrinogen gamma prime? Well, fibrinogen gamma prime is that fraction of fibrinogen molecules that contain the gamma prime chain, which is an alternatively spliced version of the gamma chain of fibrinogen. So here you see the distal portion of the FGG gene, which can be processed in 2 alternative ways. When intron 9 is spliced out and exon 9 and exon 10 are joined together, the default gamma A chain is produced, which has a short C-terminus of only 4 amino acids. However, in approximately 10% of all FGG transcripts, the proximal portion of intron 9 is retained in the mature messenger RNA and translated, giving rise to the alternative gamma prime chain, which has a completely different C-terminus. And this C-terminus happens to contain a high affinity binding site for thrombin exosite 2. So what's the physiological relevance of this? Well, as we know, exocytes are kind of interaction interfaces that thrombin uses to recognize its many substrates, cofactors, and inhibitors. So you can imagine that when thrombin exosite 2 is occupied by fibrinogen gamma prime, which is on absolute terms quite abundant in plasma, the behavior of thrombin is substantially altered. In particular, studies in model systems have shown that interaction of thrombin with fibrinogen gamma prime decreases the ability of thrombin to activate platelets, coagulation factors 5, 8, and 11, the anticoagulant protein C, and the fibrinolysis inhibitor TAFI, whereas factor 13 activation does not seem to be affected. Moreover, fibrinogen gamma prime protects thrombin from inhibition by its natural inhibitors, antithrombin, and especially alpha-2 microglobulin. Some of these effects, indicated in green, are anticoagulants, but other, indicated in red, are procoagulant. So what is now the net effect of fibrinogen gamma prime on thrombin? Well, to find out, we ideally would need a global assay that simultaneously probes all these functions of thrombin. And there are, to my knowledge, very few assays, if any, that can do that. Our best try was thrombin generation at low tissue factor in platelet-poor plasma. And this probes these reactions here, so only a subset of all reactions. And when we titrated a small peptide that mimics the C-terminal part of the gamma prime chain in this system, we observed a dose-dependent inhibition of thrombin generation, indicative of an overall anticoagulant effect of gamma prime. And I can tell you that even when we included thrombomodulin in the system to incorporate the activation of protein C, this was still true. So in summary, the fibrinogen gamma prime chain is a natural splicing variant of the gamma chain present in 8 to 15% of all fibrinogen molecules. It binds thrombin exosite 2 with high affinity, thereby inhibiting several thrombin functions with an overall anticoagulant effect. And this is in line with the epidemiological finding that low fibrinogen gamma prime levels are associated with an increased risk of VTE. So conversely, we might expect that increasing the relative expression of the gamma prime chain without changing the total fibrinogen level may protect from VTE. The second example comes from the rather mysterious East Texas bleeding disorder, which was described a few years ago in a large family from Texas. This bleeding disorder was characterized by prolonged PT and APTT despite normal levels of all coagulation factors. And by a purely genetic approach, it was linked to a point mutation in the factor V gene, A2440G. However, for some time, it was not clear how this mutation, which predicts a very trivial amino acid substitution in the B domain, could actually cause the phenotype, until the factor V was blotted. And then it was observed that all affected family members had an additional low molecular weight factor V band, which was smaller than the normal factor V band, and which they called factor V short. And the presence of factor V short in plasma of affected individuals correlated with a massive upregulation of the anticoagulant protein TFPI alpha. So this offered an explanation for the low thrombin generation in these individuals and for their bleeding tendency. But where does factor V short come from, and what does it have to do with TFPI alpha? Well, to understand that, we need some background on factor V. Here you see the normal factor V molecule as we have always known it. And as you can see, it has a large B domain, which contains a basic and an acidic region. And these two are normally engaged in a high affinity interaction, which is very important to keep factor V inactive. TFPI alpha possesses a basic region that is highly homologous to the factor V basic region and actually competes with it for binding to the acidic region of factor V. And as a matter of fact, a large fraction of plasma TFPI circulates in complex with factor V, which protects it from truncation and cleavage and clearance in the circulation. The B domain is encoded by a huge single exon in the factor V gene. And what we've learned from the East Texas bleeding disorder is that this exon contains an embedded intron. When this intron, which occupies the central portion of exon 13, is spliced out, the factor V short isoform arises, which is characterized by a much shorter B domain, lacking the basic region, but retaining the acidic region. And because of lack of competition by the endogenous basic region, TFPI alpha is much more likely to bind to factor V short than it is to bind to normal factor V. So we now know that we all have factor V short. It is expressed in every one of us at a very low level, but the East Texas bleeding disorder mutation upregulates the factor V short specific splicing event, thereby increasing the levels of factor V short and parallelly increasing the levels of TFPI in plasma. At present, we know very little about the functional properties of factor V short, but when we reconstituted factor V depleted plasma with the same amount of factor V or factor V short, we observed that factor V short supports much less thrombin generation than factor V, suggesting some kind of anticoagulant property, which is probably related to TFPI, because when anti-TFPI antibodies were added to the plasma, the difference between factor V and factor V short was almost completely abolished. So in summary, factor V short is a natural splicing variant of factor V, which accounts for approximately 5% of plasma factor V in normal individuals. It binds TFPI alpha with high affinity, resulting in an anticoagulant effect. And when it is increased 3 or 4 times, it causes a moderate bleeding tendency. So by extrapolation, we can predict that increasing the relative expression of factor V short may also protect from VTE, for example, in thrombophilic individuals. And this brings me to my second question, whether we can target alternative splicing to prevent VTE in thrombophilic individuals. To answer this question, we need to understand how splicing decisions are made and how we can influence them. Splicing decisions are dictated by the so-called splicing code, a series of signals that are embedded in the very sequence of the primary transcript. The most important signals are the donor and the acceptor splice site that mark the beginning and the end of each intron and that are directly recognized by components of the splicing machinery, the spliceosome. However, since the consensus sequences that define the donor and acceptor splice site are very short and degenerate, they can occur just by chance in many places in the genome. And that's why the splicing code has additional signals called splicing enhancers and splicing silencers that help the spliceosome identify the genuine donor and acceptor splice sites. So if we know this, we can influence splicing decisions by using antisense molecules that specifically mask signals, for example, splice sites or accessory splicing signals on the primary transcript, and thereby direct the spliceosome to desirable splice sites. And these antisense molecules can be synthetic oligonucleotides, which come in different chemistries with different properties and are at present the most popular tools, or they can also be engineered small nuclear RNAs, which have the advantage that they can be stably introduced in cells for permanent effect. And by using these antisense molecules in creative ways, we can obtain a whole range of different splicing outcomes. For example, by covering with an antisense molecule a donor splice site, we can skip the preceding exon, or we can favor the usage of an alternative donor splice site which comes upstream or downstream, and which is normally not used because of competition by the main donor splice site. Or by masking a splicing silencer, for example, we can enhance a splicing event that usually occurs at a very low rate because it is suppressed by the silencer. This technology is finding increasing applications in the correction of splicing defects responsible for several Mendelian diseases. We also tried the rescue of a splicing defect responsible for severe coagulation factor V deficiency in one particular patient. And as you can see here, by using a morpholino oligonucleotide or a U7 small nuclear RNA specifically designed to target the mutation and mask the incorrect splice site introduced by the mutation, we were able not only to correct and normalize the splicing pattern of the factor V messenger RNA in vitro, but also to restore factor V expression in the patient's megakaryocytes ex vivo, as indicated here by the green fluorescence. And these splice-switching antisense oligonucleotides are also quite effective in vivo, and therefore, under preclinical evaluation as therapeutics for a wide range of diseases, not only genetic diseases, but also multifactorial diseases such as cancer. And in at least 3 cases reported here in red, they have reached the clinical trial stage. So coming back to venous thrombosis, and this is now the main message of my presentation, we can envision that thrombophilic individuals might benefit from treatment with antisense molecules designed to target specifically, for example, the FGG gene or the factor V gene, and to shift their splicing pattern in favor of the minor isoforms gamma prime chain or factor V short, which through their anticoagulant properties might be able to restore the hemostatic balance. The advantages of this approach would be the general high specificity and low toxicity of antisense molecules, the fact that the liver, where these genes are expressed, is a relatively easy organ to target, and the possibility to stably express the therapeutic antisense sequence in hepatocytes via U7 small nuclear RNA for ideally permanent correction of the thrombophilic defect. The challenges that this approach poses are related to the fact that for the approach to be successful, all hepatocytes, or at least a large fraction of them, would have to be efficiently targeted. The dosing would be a very critical issue to make sure that the hemostatic balance is restored but does not tilt towards the hemorrhagic side. And in the development phase, this approach might suffer from the fact that there are no readily available animal models. So, in conclusion, several coagulation factors and inhibitors have minor splicing variants with unique functional properties. I have now presented 2 examples, but I believe there might be many more still to be discovered. The expression of these splicing isoforms varies among individuals and may contribute to shape the individual's risk of VTE. So in other words, these splicing variants could function as biomarkers of VTE risk. And most importantly, antisense approaches aimed at increasing the relative expression of splicing variants with anticoagulant properties might represent a new strategy to restore the hemostatic balance in thrombophilic individuals. And this is the main idea behind this presentation. I will be very glad to hear your thoughts and feedback on this. And last but not least, I would like to acknowledge all the people that have contributed to these studies, and thank you all very much for your attention.
Thank you very much for this very stimulating presentation, which is now open for discussion. Are there any questions from the audience? Let me start off. I was wondering if you shift, for instance, from towards more factor V short. Do you have data to indicate that the overall level of factor V expression will remain the same? So if you start shifting from one form or the other, it might also influence the total amount of the protein. Do you have any data?
No, the general idea would be to keep the factor V level constant and only, let's say, shift from one isoform to the other, under the assumption that, let's say, the main isoform, the factor V, is predominantly procoagulant, and the factor V short, well, can do exactly the same as factor V, but in addition has also anticoagulant properties, and that would be the modulator of the phenotype. That's a little bit the thought behind it.
Okay. And the second,
second
question that I have is, you presented some data on the severe factor V deficient patient from Italy. So what's keeping you from curing?
Well, as we all know, it takes a long way to, let's say, take an in vitro or ex vivo even proof of principle to in vivo because of, let's say, rules that have to be observed, of course, and also because to preserve, let's say, the safety of the patient. And the main difficulty with this type of approach is that every antisense molecule is technically a new drug that has to be tested for not only for efficacy but also for safety. And it is basically impossible to start a clinical trial with a drug that is specifically designed for a single patient, because it will only be helpful for that individual patient and not for healthy volunteer or for any other patients that have different mutations. And this is a big obstacle in the in vivo translation. Recently, I had the opportunity to speak to an Australian professor that has brought some of these antisense oligonucleotides to the clinical trial phase. And he said that authorities are relaxing their requirements for the in vivo translation of antisense oligonucleotides. And if you have an in vitro and ex vivo solid proof of principle, and you have a panel of non-toxicity in different animal models, you could, in principle, inject the drug in a patient. But I'm not an expert in this part, let's say, of the translation. I'm a basic scientist. I work with cell cultures and molecules.
Okay, thank you. Any other questions from the audience?
Elisabetta, this is Saskia. Congratulations, beautiful talk, and I think a very beautiful concept. As a clinical person, I wanted to know how you feel that this relates to, for instance, other types of modulating the balance, the hemostatic balance, because in thrombophilia, well, I don't have to tell you, only a minority of patients actually do get thrombosis. And for instance, in the case of having more factor V short molecules, why wouldn't we just simply give a little bit of TFPI to those patients?
Right. You're right. So, well, this is a very fundamental question, whether we need an additional strategy to target thrombosis, and especially a complicated one when we have a wide variety of treatments that are effective and safe. And I think, well, this is a kind of natural way to modulate the phenotype, because there is, of course, a wide variation in the relative expression of these splicing variants between people. And people that have, for example, higher levels of fibrinogen gamma prime or factor V short might naturally be protected. And by this approach, we would mimic that kind of natural protection. And the other thought that, let's say, is appealing to me is the idea that with this type of technology, you can go both ways. So by modulating the balance the other way around, so by upregulating the procoagulant isoform, you would be able to treat bleeding disorders as well. And I like that idea that you can go both ways. So it's a little bit of idealistic idea.
Okay, if there are no other questions, thank you again. I have a small token of appreciation from the organizers of the meeting. Okay, with that we will go to the second speaker, Cecilia Beccattini from Italy, who will discuss key points in the diagnosis and treatment of venous thromboembolism. Dr. Beccattini.
Thank you very much, Dr. Riesma. Good morning, everyone. First of all, please let me thank you, the organizing committee of this meeting, for the kind invitation to be here with you today. And in the next 15 to 20 minutes, I would like to discuss with you some issues concerning the diagnosis of venous thromboembolism and the treatment of the disease. So let's start with diagnosis, and indeed I have to admit that only a few studies have been recently conducted on the diagnosis of venous thromboembolism, and these studies were mainly dedicated to assess whether we can reduce the number of patients with suspected pulmonary embolism that should proceed to computed tomography. And this is an important issue for both the cost to the health system, but mainly also for the problem of radiation exposure to the patient. And one strategy could be to increase the number of patients with suspected pulmonary embolism who receive vein ultrasonography for the detection of deep vein thrombosis. And recently, a meta-analysis has been published on these issues, 15 studies assessing the role of compression ultrasonography, so 3 points scanned in the patients, or complete compression ultrasonography, that means the whole limb, including distal veins, for the diagnosis of pulmonary embolism. And the results of this analysis showed that compression, 3-point compression ultrasonography has a low sensitivity, so we cannot rule out pulmonary embolism based on a negative compression ultrasonography, but the specificity is quite high. So if you find a proximal deep vein thrombosis, maybe this particular patient can skip computed tomography. And when you move to whole limb ultrasonography, then you can increase a bit your sensitivity for venous thromboembolism, but indeed the specificity decreases so that probably you cannot avoid computed tomography in a patient based on a diagnosis of distal deep vein thrombosis. The other strategy, more than compression ultrasonography, could be the use of age-adjusted D-dimer. As a clinician, I know very well the nightmare of D-dimer in the elderly patients when you can exclude venous thromboembolism only in a very small proportion of the patient with the suspicion of the disease based on D-dimer. So our Switzerland colleagues try to assess the role of a D-dimer with age-adjusted cutoff levels in those patients who are aged 15 or over years. And they found that this kind of strategy can be of value because, as you can see in a large cohort of patients with suspected pulmonary embolism, the failure rate at 3 months of this age-adjusted strategy is 0.3%, and even the upper bound of the 95% level is 1.7. That means, okay, this strategy is not perfect. You can have some failures, but this failure at the maximum can be 1.7%. And in my opinion, I believe that this can be an acceptable failure rate, even though probably we need more confirmation of this kind of strategy, of the accuracy of this kind of strategy. So let's move to treatment of the disease. And I would like to concentrate my talk into 3 points: the acute phase management, the agents, the optimal agents for treatment of the disease, and the duration of treatment. The acute phase issue is mainly based on whether we are if all of us is convinced that the treatment of all the spectrum of venous thromboembolism, distal deep vein thrombosis, proximal deep vein thrombosis, subsegmental pulmonary embolism, or high-risk pulmonary embolism need the same treatment overall. And indeed, we know that the problem mainly exists with acute pulmonary embolism patients in the acute phase, where we know that the European Society of Cardiology proposed an algorithm for risk stratification for the risk of short-term death. And we know that patients that are admitted in shock or sustained hypotension can die, have the possibility to die in a proportion that is between 15 and 30% of the cases. So these patients are considered at high risk. And this subgroup of patients is quite different from those patients that are categorized as low-risk patients, mainly based on hemodynamic stability and on a low risk level based on clinical prediction models. This subgroup of patients has a risk of death that is about 1% at 30 days. So I believe that we all should be convinced that these two categories of patients are pretty different, but the majority of the patients with acute pulmonary embolism probably stands in the middle, and they are those called to be at intermediate risk for death. And we recently simulated what happened to your population of everyday patients with acute pulmonary embolism is if you use the ESC model 2014, and indeed we have to admit that even in our everyday cohort, you can identify a subgroup of patients that has a high risk for death at 30 days, a group of patients that probably will have a good prognosis just based on a clinical prediction model, but also we have a group of patients that has a mortality risk at 30 days that varies between 7 and 6%. That is not negligible. Indeed, if we look at the accuracy of the ESC prediction model, the possibility to further subdivide intermediate risk patients into an intermediate high and intermediate low risk category is not so accurate. But anyway, maybe that some further works can be done on that. And so the problem is, we know that we have to spend all our efforts in order to reduce mortality in high-risk patients. Probably we have, let's say, patients with acute pulmonary embolism that will have a good prognosis if they stand on the low-risk category. But do we need something more for this group of patients that has a risk of death of 7% at 30 days? And indeed, if we look at what we have now in our hands, we know that a large randomized trial was conducted some years ago in patients with acute pulmonary embolism that were hemodynamically stable, with right ventricle dysfunction and increased troponin. And indeed, this randomized trial found that thrombolytic therapy is able to reduce the combined endpoint of death or clinical deterioration in these patients. But as you can see, this result was achieved mainly by the reduction of hemodynamic deterioration, while the results on mortality were not so much convincing, and at the cost of a clear increase in the risk for hemorrhagic stroke and for major bleeding at 7 days. So based on these results, current guidelines discourage the use of thrombolytic therapy in these patients with acute pulmonary embolism who are hemodynamically stable. And the other option could be the insertion of a vena cava filter. We know from the literature that some data exists on a potential benefit from the insertion of vena cava filter in patients with acute pulmonary embolism in terms of reduction in mortality. This was a large randomized trial, almost 400 patients with acute pulmonary embolism randomized to insertion or not insertion of vena cava filter. And indeed, you can see that both in the acute phase, but even in the long term, the presence of the vena cava filter was not associated to a reduction of recurrent venous thromboembolism and not to a reduction in death. So I would say no place for thrombolytic therapy, no place for vena cava filter insertion. But anyway, we still have a subgroup of patients with an increased risk for death. So I believe that this issue should merit further attention in future research. But as far as we are, all these patients should receive anticoagulant treatment, either in hospital or maybe at home, or with thrombolytic therapy on the top if they have cardiogenic shock or sustained hypotension. So the point is, anticoagulant treatment. We know that now we have several agents for anticoagulant treatment in patients with acute venous thromboembolism, oral agents with no need for laboratory monitoring or dose adjustment have been tested, and all dabigatran, rivaroxaban, apixaban, and edoxaban were non-inferior to conventional treatment for the treatment of acute venous thromboembolism. And even if we select those patients that were included in phase 3 trials for initial acute pulmonary embolism, then we can see that even in this subgroup of patients, the direct oral anticoagulants probably are non-inferior to conventional therapy. I have to admit that we don't know nothing concerning the, let's say, right ventricle or troponin issues in these patients included in the large phase 3 trial. We only know that these patients were included if they did not have an indication for thrombolytic therapy. So probably all of them were hemodynamically stable, but we don't know nothing concerning risk stratification. And we also know that direct oral anticoagulants probably offer some advantages also in those patients with venous thromboembolism that we believe by clinical point of view they are frail, and in particular those with age over 75 years old and with borderline renal function. In these patients, the new agents probably can even be safer than conventional treatment. So, based on this data, current guidelines recommend the use of the direct oral anticoagulants as the first-line treatment, as a treatment of choice for the majority of the patients with venous thromboembolism. As you can see, this is not valid for those patients with concomitant cancer. In these particular patients, the guidelines still recommend the use of low molecular weight heparin because we have only limited data. So this is what we have for our clinical practice, a large armamentarium of drugs that you can use both with a pre-treatment, with a lead-in of parenteral treatment, or just by the oral route since the beginning if you are using rivaroxaban or apixaban, and also a parenteral approach by LMWH. So now you have lots of drugs to treat our patients with acute venous thromboembolism. But I have to say that still we need some data, some additional data concerning cancer patients, concerning whether we can safely treat patients with acute pulmonary embolism at home, on children and on pregnant women, and probably some more data is needed for those patients with acute pulmonary embolism that are not at low risk, but with some kind of hemodynamic impairment. Let's move rapidly to the duration. We have a problem of duration of treatment because we know that venous thromboembolism tends to recur after a first episode, either if it is a deep vein thrombosis or a pulmonary embolism. Probably the risk of recurrence is much lower if you have a distal deep vein thrombosis. But anyway, we also know that the risk for recurrence is higher in patients with an unprovoked event. That means that you cannot find any risk factor for that specific thromboembolic event, and it occurs without any triggering factors. In these patients, the risk for recurrence is highest immediately after discontinuation of anticoagulation, then the risk decreases over time, but remains higher than the risk for recurrence in patients with provoked venous thromboembolism. So most of the research concerning the optimal duration of treatment concentrated on these particular patient populations who suffered a first unprovoked venous thromboembolism. And the first point is whether this patient candidate for a time-limited prolongation of anticoagulant treatment, so not just 3 months, but 1 year, 2 years. And this is the most recent study with this kind of experimental design that has been published. This study included patients with unprovoked pulmonary embolism. All these patients received anticoagulation for 6 months and then were randomized to stop anticoagulant treatment or to prolong it for additional 18 months. And the authors found that obviously anticoagulation is effective until the patient is on treatment, but when treatment is discontinued, the time-limited prolongation of anticoagulation does not protect against the risk of recurrence after discontinuation. And these patients who prolonged treatment up to 24 months have similar risk for recurrence as those who were treated for 6 months. So this is not the way to go. Because if you prolong your treatment for 6 months, for 12 months, then you delay the risk for recurrence, but you do not decrease the risk when treatment is discontinued. So the other point could be to prolong in all patients after an unprovoked venous thromboembolism, but we know that we have to face with bleeding risk and that we not have any tools to stratify for the bleeding risk. So the actual recommendation is to stop treatment after 3 months in all these patients with low risk for recurrence that are mainly patients with provoked venous thromboembolism, to continue indefinitely in those patients with very high risk for recurrence, so cancer patients or patients with recurrent episodes. But the point remains, in those patients who suffered a first unprovoked venous thromboembolism, Now we know that we have anticoagulant agents that can be safer than warfarin for standard treatment, and agents that used even at prophylactic doses can reduce the risk for bleeding when used for standard treatment. So I believe that after the initial 3 to 6 months of treatment in patients who suffered an unprovoked venous thromboembolism, we have now 4 possibilities. The first is to stop in all patients, because I know that time-limited prolongation will not save the risk for recurrence. To continue in everybody and accept the bleeding risk, and in this case, please use the NOx because we know that the bleeding risk is probably lower. Or we can stratify according to some prediction models that have been proposed, the Vienna prediction model, the D-dimer strategy, the residual deep vein thrombosis, but please consider that none of these strategies has been appropriately validated in order to be recommended. The other point is to continue to protect our patients with alternative strategies. We know the story of aspirin, of sulodexide, or low-dose warfarin, or low dose of apixaban. We know that a study is currently ongoing aimed at assessing the value for a standard prophylaxis with rivaroxaban 10 milligrams, that is probably the same as apixaban 2.5 milligram twice daily. So the results of this study probably will be available in the next weeks. So maybe this will be a further strategy to prevent, for secondary prevention of venous thromboembolism. And now, this is my last slide. I believe that we can conclude that we have solid data on the need for tailor our diagnostic and treatment strategies to the severity of venous thromboembolism. And we now have agents that can be easy to use and probably safer than conventional treatment for the treatment of venous thromboembolism. And please consider that duration of treatment should be probably individualized based on the risk for recurrence. Thank you very much for your attention.
Thank you very much for this overview. It's now open for discussion. Are there any questions from the audience? Maybe I can start off. You only spent 5 minutes on diagnosis, so that field is mature and...
On diagnosis, sorry?
Of your talk, you spent 5 minutes on the diagnosis of PE. Does that mean to indicate that that field is mature and that there is nothing to do? There are no new methods or to develop?
No, okay. Indeed, I have to admit that some data also exist, for example, on NMR. Indeed, the studies with NMR are not so much promising, and probably because, as you know, the patient with acute pulmonary embolism is dyspnoic, so it cannot stay 30 minutes, 40 minutes under the NMR, and so the images are probably not so much accurate. But anyway, we know that some research is still ongoing on low radiation strategies with CT scan or with the use of low quantity of contrast media. So something more is going on. In the meantime that we wait for some, let's say, low-risk computed tomography strategies, I believe that the use of the age-adjusted D-dimer strategy probably is a good strategy. And the other point is the role of venous ultrasonography. Here the point is that it strongly depends on the hospital organization, because sometimes it's more easy to have a CT scan than to have a compression ultrasonography. So it is also a matter of time, because you have to start treatment, and you know that in patients with acute pulmonary embolism, if you start treatment in time, you can reduce the risk of death. So the diagnostic strategy probably should also be tailored on what you can have, because if you make a compression ultrasonography before a CT scan, you can save about 8 to 10% of CT scan. So my opinion is that, first of all, use age-adjusted D-dimer. If you can, please use compression ultrasonography before computed tomography, and let's wait for the results of low radiation strategies. But anyway, you're right. The research field on diagnosis is, let's say, a bit slow, probably because now we have some methods that have a high accuracy for diagnosis.
Okay. There's a question there.
Yes, Jaime Borjas from Groningen. It was sort of the same question about diagnosis. I read this entry in the Clot blog by Sam Goldhaber, and was talking about overdiagnosis or misdiagnosis of pulmonary embolism, and he cited a study in which expert radiologists, 3, they had to be unanimously agreeing that there was a misdiagnosis of pulmonary embolism, and this was a single center study. And what they saw, at least these expert radiologists said, 25% of the original positive CT scans were adjudicated as negative. So this has a lot of implications for different things, because if we're basically saying to a quarter of our PE patients, we were wrong, you don't need the treatment, and we're working on this false assumption, and it has a lot of implications on what we communicate prognostically. So I'm sort of wondering what your stance is on, is this something we should be solving? Because it didn't come back in the talk.
Okay, so if we go back to the PIOPAD study, we know that this sort of misdiagnosis is particularly pronounced not for central pulmonary embolism, that means the main pulmonary arteries or the lobar arteries, but probably there can be some problem of agreement on the assessment of pulmonary embolism when you move to distal branches of the pulmonary arteries that are the segmental and subsegmental arteries. Now, the problem exists, and I have to repeat that if you read carefully the results of the PIOPAD-2 study, there are about 25% of the cases where the diagnosis is, where you have a problem with diagnosis. But anyhow, I believe that the problem is also rising with recent generation CT scanners, because we know that by implementing the technique, you can visualize even better the distal arteries, but probably you have the risk of overdiagnosis, not just of losing diagnosis, but also to expose the patients to a bleeding risk connected with anticoagulation, and the disease was not there. But indeed, I believe that even though these problems are real, so I believe that we should, let's say, improve also the quality of radiology reading of CT scan. The problem is difficult to solve, because this is right the same problem we had with perfusion lung scan. So don't forget that even though you use perfusion lung scan, you have about 35 to 40% of undetermined examination. So the problem is still there. Probably we have to improve the radiology reading of CT scan, and probably this is, let's say, an ongoing problem, because by changing the, let's say, the methodology of CT scanners, you have also to adapt your diagnostic criteria. And at the moment, I have no solution for this, if not to improve our diagnostic methods. And as I was saying, some research is still ongoing on low radiation exposure and some differences in the use of contrast median. There are some studies on double bolus of reduced doses in order to improve the venous phase of CT scan images. So let's wait for this further data. But the problem is there. So you get a right point, and still something more has to be done for the diagnosis of PE.
Thank you. Dr. Middeldorp.
Thank you very much, Cecilia, for this very comprehensive overview. There are two things that I would like to add, if I may. The Dutch group, led by Menno Huisman, presented at ESC in Rome the year's strategy. Because I think the Adjust is beautiful, we all collaborated and it works. I'm pretty convinced, even though you might argue that we need even more narrower confidence intervals. But the problem with the adjust is that it only protects people that are older than 50 for getting unjustified scans based on their D-dimer. And it does not do anything for the young ladies and the young men who have a longer time span with radiation. And the years criteria actually are 3 Wells criteria. This was derived from the numerous diagnostic studies. And if you have none of those 3, the cutoff of the D-dimer is 1,000, so regardless of age. So that really even improved the number of CT scans that we could withhold, also in younger people, I thought. And the failure rate is excellent. So I think that is the way to go, not just age discriminate people because they're old or young.
Yes, you're right, Saskia. Thank you. Due to time constraints, I had to concentrate. But
yeah. I just thought it was good to mention, because in the Netherlands it's common practice, it's standard practice in the hospitals who actually performed the diagnostic strategy study. And the other question I would like to ask you, what would you do tomorrow if you would have asymptomatic subsegmental PE? Of course, it also is in line with the diagnostic problems. Would you treat or would you not treat?
Okay, it depends on the clinical setting, probably.
Painful, painful. Painful, otherwise healthy.
Okay, if I have a clinic, I believe I have to treat.
Yeah.
Anyway, I have to admit that I have no data. Also, for the point that was addressing the speaker before. So, how are we sure that subsegmental PE is effectively there? But I believe that if you have a positive CT scan and the patient is symptomatic, it's hard not to believe, not to trust.
I fully agree.
So I believe that for what we know now, you have to treat the patient. If we can do a clinical trial, please randomize this patient to be treated or not to be treated. But the clinical trial should be done. So as far as we are, I don't know.
Yeah, I know that Marc Carrier is doing one, and also in France, and I feel that it must be difficult to get informed consent from patients, but apparently it's working. I just checked, Canada and France are randomizing these patients.
And this is a problem, because if the patient is symptomatic, it is the same story of distal deep vein thrombosis. If the patient has symptom and you have the finding, it's difficult to say, okay, you have nothing, you don't need treatment.
Yeah, I agree. Thanks.
Okay. There's one more question there.
Excuse me. In high-risk patients, high-risk VT patients, when we decide to holding the treatment after 6 months or 12 months, is there any recommendation or is there any suggestion to taper to DC of anticoagulation or not? We have to stop it suddenly. And the second question is this, any ongoing study for the children on NOAC? And because pediatric hematologists have some more problems with warfarin than adult hematologists. And we are waiting for the results of this study in the world.
Okay, thank you very much for your questions. Indeed, I know that there are some studies that are ongoing with some oral formulations of dabigatran and apixaban for children, probably also with rivaroxaban. So the NOACs are tested on children, but still we are waiting for the results because you have a problem of those findings in the children. So something will be available, but I don't believe it will be before than 1 or 2 years since now. And in the meantime, I believe that you have to go on with conventional treatment, okay? And the other point is whether we need to, I hope I understand correctly your question, whether anticoagulation should be slowly decreased or interrupt. Indeed, as far as we are, you have no data on, let's say, that you need to slowly decrease your treatment with warfarin. So warfarin does not cause a rebound if you are at the end of a long-term treatment. And we don't know with the NOACs, but probably there is no rebound phenomenon. So when you discontinue treatment, you can stop it and go on with nothing, okay?
Okay, if there are no further questions, thank you again, Dr. Beccatina. I have a small present for you from the organizers. Okay, and with that I would like to close the session and thank the audience for their presence and partaking in the discussion. Thank you.